Hello, welcome to Birth Vibe, a podcast by BirthRight by Rainbow Hospital. Today we are going to discuss about placenta previa and adherent placenta. Most of the pregnancies they progress very smoothly. They don't need extra care and extra vigilance and planning, but there are certain conditions which require these kind of planning and multidisciplinary care to ensure that the pregnancy goes smoothly and we have a safe mother and a safe baby. Amongst these conditions, one of the condition is the placenta previa and adherent placenta. Placenta is an organ which takes blood from the mother and gives it to the baby. So, the position of the placenta is important. When the placenta is implanted, is attached to the uterus in the upper part, generally that happens and it gets expelled after the baby is born. But in few cases, the placenta gets attached to the lower part of the uterus at the entrance of the womb and causes problem. And the other thing is after the delivery, the placenta may not get detached and that causes excessive bleeding. So this condition where the placenta is in the lower segment is called placenta previa, and when it is not getting detached after the delivery, the condition is called adherent placenta. In these two conditions, there is a problem to the mother as well as to the baby, which can lead to excessive blood loss in the mother and also a premature delivery in the baby. So, in these conditions, we need to have an extra planning, extra care to ensure there is a safe delivery. Today, we have Dr. Subrahmanyam sir, Chief Anesthetist in Rainbow Hospital, BirthRight by Rainbow Hospital, and we are going to discuss about anesthesia related problems in these patients. Generally, anesthesia is a simple thing to give comfort to the patient, but in these cases, there is something extra which an anesthetist has to do to ensure a good outcome. Welcome, sir.
Thank you. Thank you, Shruthi.
So, when we have these cases of placenta previa and adherent placenta, when we diagnose and tell you that this case is now there in the labor ward, what is the first thing you think about management and how is it different from a regular case, sir?
So basically, as you said earlier, pregnancy is quite straightforward, and we have a standard anesthesia for all deliveries of cesarean section. But when we anticipate problems like placenta previa, we may have to alter our anesthesia depending on the grades of that placenta and the grades of the adherence to the uterus. So ideally, we would be happy to see that patient maybe a few weeks before, so that if there is some extra investigations or extra tests needed, they can be done, and we can plan and explain to the patient in a better way.
So, when do you generally want to see this patient in the ninth month when they enter the ninth
So
month?
at
Or?
least, as I said, 2 to 4 weeks before. And sometimes we ask for, of course, you would have yourself evaluated, but sometimes an MRI test would actually show the degree of whether the placenta is stuck to the uterus or not. And that helps us plan the kind of anesthesia which we have to do looking at that. And in some severe degrees, as you know, when this placenta is so adherent, we may have to end up removing the uterus. We may not be able to remove the placenta at all. And along with the baby's delivery, you may have to remove the uterus, which has big implications for the mother because she will not be able to conceive again.
Yeah. So basically, there is a little bit of amount of blood loss we expect in any case in a cesarean section. So how is it different for you when compared to a normal case? How is it different in this placenta previa?
Okay, so in a regular case, there is a condition called PPH, which means postpartum hemorrhage. So postpartum hemorrhage is bleeding which happens immediately following the delivery of the baby, and the incidence is very low. It may be less than 3 or 4 out of 100 who have this bleeding, and it is sudden. We don't know in which patient this bleeding is going to happen. So all pregnancies can potentially have this complication called PPH, but this instance of this bleeding is significantly higher in placenta previa and the adherent placentas. So invariably, we have to reserve blood and blood products before we plan anesthesia.
And more so because this is a massive blood loss. which happens in a very short duration.
Yes.
Sometimes when we give a cut, it kind of comes out like a tap which is opened up, and that's kind of a blood loss.
Yeah.
So how is it different, that blood loss, how is it different from a slow blood loss to
Okay,
use?
so basically we have to plan, as you said, for sudden blood loss. So we do a lot of invasive monitoring or advanced monitoring. So when we anticipate blood loss to be massive, which means about normally the blood volume in a grown adult is roughly 5 liters. So we have 5 liters of blood in our system. So any loss which is more than 2.53 liters is called a massive blood loss. And if you anticipate that, you have to have all these products ready, and also you should have monitoring, because when you have blood loss you will have fall in blood pressure, you will have heart rate increasing, so all these should be monitored. Now, monitoring blood pressure, normally we put a cuff on the arm, which is the standard way of monitoring blood pressure. But we also have an advanced way of monitoring where we put a small needle in this artery in the hand. So it's like you put an IV in the vein, we put a small IV cannula in the artery, so that every beat you get a tracing of the blood pressure. So that gives us a much closer monitoring of the blood pressure, and we can track when the blood pressure is falling before you pick it up on the cuff monitor. So this will need explanation to the patient, and invariably when we anticipate a severe blood loss, we also change the anesthesia plan from spinal, which is normally done where we have the patient awake during the delivery, to a general anesthesia.
So that is what my next question is, that type of anesthesia changes in these patients.
Yes, so because there is going to be a lot of blood loss and we give a lot of blood products, there's a lot of tension going on in the operation theater, and the patient may feel very apprehensive if they are awake. And second, also when you give all these products rapidly, they cause fall in temperature. Like blood, as you are aware, is stored in deep refrigeration. So it comes at a temperature of about 5 or 6 degrees centigrade, and whereas our body temperature is 36 centigrade. So if I transfuse blood which comes from the blood bank at that temperature, the patient's temperature will fall. So all this is very uncomfortable if the patient is awake, if the mother is awake and able to perceive all this. So we would prefer that it's a general anesthesia when you anticipate a significant amount of blood loss.
In order to just have a control over the blood pressure,
To give safety to the
maintenance.
mother and to have control over, because once you have general anesthesia, you can regulate by giving drugs and modulate all the parameters in a safer way.
So as we anticipate more amount of blood loss, and that too in a very short span of time, the blood pressures can fall. So in these cases, it is always better to have a control over the blood pressure monitoring. And for that reason, the anesthetists are saying that they prefer the general anesthesia, which is slightly different from a regular patient where we go with a regional anesthesia called spinal anesthesia. So considering these high risk factors, sir, what extra care, apart from, you said that there is a blood products which have to be kept ready, arterial line has to be placed. So what extra care do you take in these cases when you manage?
Now we are assuming that this the case is going to have excessive bleeding. So whenever we anticipate excessive bleeding, one is to monitor the blood pressure. The second is to have access to deliver blood and blood products. So normally we have an IV line which can only deliver products at a certain speed. Sometimes we have a big blood vessel in the neck called internal jugular vein, which is very significant thickness, and it allows you to give fluids at a faster rate, fluids or blood.
So that is what you call it as a central line.
We call that as a central line, which also helps you monitor the central venous pressure. So, and if you have to give drugs which bring up blood pressure called inotropes, which can also be given through this. So, and also for multiple sampling, you may have to frequently keep checking, the hemoglobin or the clotting of the blood. So for all this, you'll have access if you take a big vein in the neck. So all this we do when the mother is asleep under general anesthesia.
So for these kind of monitoring, where you are going to monitor the arterial line, your central line, and the patient is given a general anesthesia, How many anesthetists do you need, sir, for this
Okay.
managing this case?
So normally for a spinal anesthesia, one single anesthesiologist is adequate because more or less it is quite straightforward. But when you have anticipated problems like this, at the minimum we will have two people because a lot of activities go on simultaneously. If you get blood from a blood bank, you have to first check that whether the cross matching has been done correctly. You have to check the patient's blood group, and the blood coming from the blood bank is the same blood group, and that it was tested for this particular patient. Because even though the blood group is same, there is something called cross matching, which means the mother's blood is interacting with the actual donor blood, and then they see that there is no reaction, then only that blood is transfused. So checking all this takes time. So we need not only one extra anesthesiologist, we need someone to liaise with the blood bank. So typically we call these runners. So we have one or two runners who come from either the admin department or from the gynecology obstetrics department, and they help in coordinating. And apart from blood, we have products which help in improving the blood clotting ability. So it's called white blood colloquially. We call it plasma or fresh frozen plasma. Then we have other products called platelets and fibrinogen. So all these help when there is because all these products are important to allow the blood to clot. And when there is a massive blood loss, all these products are lost from the blood as part of that blood loss, and we need to give them artificially to bring up the clotting ability of the patient. So all this process for testing, ability to check, cross match, you need extra hands.
So basically, people think that okay, this is a different case, placenta previa, where the placenta is in the lower segment and needs a cesarean section definitely. So they think that okay, surgeon is enough to manage the case. If we have an expert in the surgical field, that is enough. But what do you think that what is the role of an anesthetist in these cases to get a good outcome?
So, as we already said, it's not only the role of anesthetist. I feel you need a very senior surgeon also, because you have to take quick decisions about sometimes, you have to modify what you're doing to control the bleeding because the blood loss is so massive. So, sometimes you may have to press the main artery called the aorta. We have to give manual compression to block blood going to the uterus so that you get some time to manage the ligating the blood vessels. So you need someone who can think fast, who has experience with these cases earlier. And likewise, you need a senior anesthesia doctor who, when he looks at the blood pressure, he gets an idea that, okay, this is manageable. And he should figure out at what point it is not manageable and tell the surgeon, okay, remove the uterus or take the next step. And we are not able to keep the patient safe at these parameters.
So these cases definitely suddenly the decision to do a particular surgery, suddenly the plan changes based on the blood loss. We go into the theater saying that okay, we can preserve the uterus in few cases, but sometimes because of the excessive blood loss we may have to take a decision to convert into a uterus removal surgery, which can happen most of the cases in adherent placenta. Though we depend on the blood test, MRI scans before the delivery, sometimes the decision can be changed during the delivery time during in the theater. So a senior anesthetist as well as a senior surgeon is definitely needed to have a better outcome. So how is post operative recovery different from a regular cesarean section in these cases?
So when you give lot of blood and blood products, that again causes some complications. So there can be some changes in the lung. So it's called transfusion-induced lung injuries. You can have various other issues like clotting. Even after the surgery, there could be continuous oozing from the surgery site if your clotting factors are not adequately managed. So this is an ongoing case for up to 24 hours post-operatively. We have to manage various parameters like blood pressure, heart rate, how much urine a patient is making, because that is an indicator of the perfusion to the entire body. So there are various other factors which we have to, and various blood tests to look at clotting, to look at electrolytes, and all these have to be frequently checked. So we typically keep these patients post-operatively in intensive care units for up to 24 hours.
So not just during the theater time, during the operation, I think we need to monitor these patients even post-operative recovery area also. Ideally, these patients will be managed in an intensive care unit to monitor the blood loss and also to check the blood pressures, whether they are maintaining their oxygen saturations and whether they are producing enough urine. All these things have to be taken care apart from taking care of the blood clots. So prevention also will be done. And in these cases, patient
And
asks some.
just
Yes,
to
sir.
add, one more aspect we have to take care is pain management,
Yes.
because it's a massive surgery. And in the normal cesarean section, the pain management protocols are different because we have the spinal anesthesia, which is very good for pain relief. And when you do this general anesthesia, there is significant amount of pain in the patients. So you have to manage that also, because if there is pain, they can't cooperate in your physiotherapy,
Yes.
and deep breathing will become painful. So we need to address that also.
Yeah. So patients ask, they come with these reports from the peripheries and they say that, okay, this needs a cesarean section. Can I get this done in my place, nearby hospital? So what do you suggest to them, sir?
I mean, I wouldn't say that you should not do this here or you should do that there, as long as all the facilities which you are talking about exist. So the first thing you need is ability to monitor the patient, have all these invasive monitors, the skill of the anesthesiologist to be able to do these procedures. Third, availability of blood and blood products at a very close distance. So if not in the hospital, it should be very easily accessible, because you won't have the time to run between blood bank and the hospital, because time is the essence here. So I would say in these kind of cases, ideally you should have blood bank within the hospital.
So,
So if you have all these warming devices when you are giving blood, as I was telling, because it is cold, you need to pre-warm it to a patient's temperature. So there are devices which do all that. And sometimes if the patient is cold, we have warm air blowers which take care of their temperature. So all this gadgetry costs money, which may or may not be there in a smaller hospital. So if all equipment and personnel are there, I don't see any reason why it cannot be done anywhere. But typically it does not happen. Hence, they are shifted. Those high risk cases are shifted to better equipped hospitals.
so these cases of placenta previa and adherent placenta, where the risk of sudden blood loss is more and it can actually risk mother's condition. So these cases have to be managed in a multidisciplinary care where the things are available. It is not just the surgical technique, it is how you manage the blood pressure in the mother during the operation and after the operation, as well as their urine output. Their temperature has to be monitored and well managed to have a better outcome. So we at BirthRight Rainbow do these cases in a multidisciplinary care with lot of meticulous planning and vigilance so that we ensure a safe delivery. Placenta previa and adherent placenta is not to be worried, but at the same time, we need to take more precautions to ensure a safe delivery. So, share this episode with any of your friends who is going through this kind of condition so that they can have more awareness of this problem and can plan their pregnancies in a better way. Follow Birth Vibe podcast by Birthright by Rainbow for these kind of inputs and any kind of educational material for your information. Thank you.